you guys. All right. Well, so I've given this presentation to you before. I always make a couple of addition, subtraction every year. It's basically it's a pretty big lecture, so we're going to take up the majority of this hour and then an hour next week, talking about just basically lesions that we deal with in neuropathology. So it's mainly going to be pictures focused. Just show you guys, try to get you some spotters. Talk about some the general characteristics of the lesions involved. And I know from some of the information that you guys have given me from previous years, you guys are asked about immunohistochemical stains and some genetics and things like that. So I'll kind of hit the high points of those as well. So just kick it off with infiltrating gliomas. And as you guys are well familiar with, these are inexorably progressive, universally fatal neoplasms that differ in aggressiveness. And I would say that sort of an asterisk there would be inexorably progressive and universally fatal neoplasms in adults. Children obviously get infiltrating gliomas as well, and those can be devastating. It's interesting, particularly in the pediatric age group. You have a group of tumors that are genetically like low-grade, poorly infiltrating tumors that do infiltrate and may behave a little differently than the infiltrating gliomas that we talk about in adults. But that's the asterisk. In general, infiltrating gliomas are thought of as glial-derived, and so therefore they're going to express glial markers, S100 protein, GFAP, glial fibrillary acidic protein, that's the intermediate filament of glia, and then OLIG2 is a transcription factor that's associated with glial differentiation. The infiltrating properties of these tumors determines the fact that they can't be completely resected. There's always going to be tumor cells that are beyond the knife. And what do we really mean by infiltration? Basically, it's a term that means that the cells can individually work their way through the neuropil. So I kind of think of this as, these monkeys are native to the jungle. They can swing on the vine. So if you think of the neuropil is just a bunch of vines in a jungle. Well, the individual cells can kind of work their way through. Okay, and so the fact of the matter is they can individually go well beyond where the primary tumor mass is, and we'll see some pictures of that here in just a second. But the behavior of an infiltrating glioma is related primarily to histologic and molecular findings, and these days we're more and more incorporating molecular findings in the way that we differentiate these things. The clinical course is related to where the thing is, how much of it can you cut out initially, what your treatment options are available, and the patient demographics, and of course other clinical factors, how well the patient's doing otherwise. And then there's these are, as I kind of mentioned earlier, these are different clinical and molecular diseases in children versus adults. The adult infiltrating gliomas are fairly well characterized. In pediatrics, we have a pretty decent number of categories for them, but pediatric disorders in general are, from a genetic perspective, pretty heterogeneous things. So, in any event, so these are by imaging are T2 bright expansile lesions that at higher grades will show enhancement. So the fact of the matter is, if you think about how these individual cells working their way through the neuropil, what does this look like in a patient? Basically, here we have a drawing of an infiltrating glioma, and this is the main tumor mass here. And I think they're probably trying to depict a glioblastoma here. But you can see that these tumor cells will go along white matter tracks in large numbers, but then they'll also singly work their way out into the neuropil elsewhere. And they'll do this in an interesting fashion. They actually show some of the properties that you would expect with normal glial cells, i.e. they orient themselves towards structures that usually need some type of glial support or protection. So they'll orient themselves to neurons. They'll gather up around neurons and show this phenomenon called perineuronal satellitosis. I think that's what they're trying to give you an idea about here. And then they'll infiltrate out and they'll sit along blood vessels as well. And they'll also basically continue to go through the brain and stop at the edge. So they work their way through neuropil and then they stop because they don't typically go out. They can go into the subarachnoid space, but they usually don't pass beyond the cranial cavity. And when they stop at the edge of the brain, they'll also build up along the peel surface along these lines. So sometimes if you get a section, you're going in to resect a glioma, and you take a peripheral section, well, the neuropathologist will pay a lot of attention to what's piled up along the peel surface because that may be the best look at the tumor that you get if it's infiltrating. But just in general, there's a term for the perineuronal satellitosis and the perivascular orientation and the subpeel buildup of these tumor cells. And the general term is the secondary structures of Scherer, Scherer. Scherer was an old-time neuropathologist, practiced back when you could put your name on things. So he's immortalized. So this is, from a histologic perspective, this is how we think of infiltration. So your tumor mass is going to be over here, down the bottom left-hand corner more so. And then there's a gradient of cellularity from the bottom left-hand corner of this picture up towards the top right-hand corner. So more cellularity down here, less cellularity up here. But in general, that gradient is caused by individual cells going in a general direction from the center of the tumor out away from the tumor. And you can see that they do group up around other cells. So here's a few neurons here in this section, and you can see that these tumor cells, you see most of them down here, but you can see that the tumor cells are grouping up around the neurons, that perineuronal satellitosis. And here it is around a vessel, so forth. So those are the secondary structures. All right, so for your test, I'm not sure what exactly, what classification they will probably be putting on it. As you guys probably are aware, we recently redefined some of our classifications of infiltrating gliomas. And this is the old classification, the 2007 classification. So you guys remember we basically had infiltrating astrocytomas, oligodendrogliomas, and oligoastrocytomas. And the way we told these things apart back in the day was we just looked under the microscope and we said, well, if it's an infiltrating glioma, I'll just look at the nuclei primarily, and that'll tell me whether it's an astrocytoma or an oligodendroglioma. Astrocytomas are typically thought of as having lobulated or elongated nuclei. The term that we use oftentimes is the nuclei look like Idaho potatoes. I don't know if you guys have heard us talking about that before. Idaho potatoes for astrocytoma. And then oligodendrogliomas, very rounded tumor nuclei, and those look more like Florida oranges. Okay, so we look around at the tumor and we'd say, it's got a lot of potatoes. It's an astrocytoma. Well, this one looks like a bunch of oranges. It's an oligodendroglioma. And then if you saw a bunch of mix of the two, well, it's got some potatoes and oranges. Well, it's an oligoastrocytoma. So that it made a whole lot of sense to us that there was some clinical difference, obviously, between these two things. So we thought we knew what we were doing, but in general, this classification only sort of scratches at the surface of what the underlying molecular classification of these things is, and we'll get into that in just a second. So just give you some pictures of what I'm talking about here. So if you're talking about astrocytic nuclei, they're going to have irregular nuclear contours. So this would be an example of something along those lines, irregular nuclear contours, a very, very odd-shaped nucleus. And you can see numerous guys that look like this scattered around through this tissue, okay? So I don't know if you'd buy that potato in the supermarket, but it doesn't look like an orange at least. Whereas an oligodendroglioma, very rounded tumor nuclei. And you guys all remember the fried egg cells of oligodendroglioma, the perineuronal clearing, or not perineuronal, but pericellular clearing that makes these cells look like fried eggs. This is an artifact of fixation, so it's not present on a frozen section. It's mainly present in a formalin-fixed section. But in general, the main thing you're using to guide yourself to tell things in oligodendroglioma is the rounded tumor nuclei. So then when we looked at tumors with a mixture of those two, big weird cells, as well as lots of tumor cells with very rounded tumor nuclei, well, we saw, well, it's kind of a mix of the two. It's divergent differentiation. So we would say, okay, oligoastrocytoma. So, and in general, our grading of these things follows the criteria. It's called, we call it AMIN criteria. And that's atypia is what's necessitated to call it a grade 2. Basically, in order to call an infiltrating glioma, you need to be able to see atypical infiltrating tumor cells. So that's number one. Mitotic figures would allow you to get the tumor up to grade 3. And then EN is endothelial proliferation and necrosis. So, of course, those would be indicative of grade 4 if you're dealing with an astrocytic tumor. And then oligos have a slightly different cutoff for these different levels, and oligos don't have a grade 4 variant of an oligo. In the instance where we used to think of these things as having mixed classification, that oligoastrocytoma, there was a category called glioblastoma with oligodendroglial component. And so the idea was that, well, if an oligo got really bad, well, it would show differentiation into an astrocytoma at high grade and would become a GBM at that point. Nowadays, basically, we define oligos by IDH mutations and 1p19q codeletions, and in that scenario, they don't ever get to grade 4. They just stay at grade 3 anaplastic oligo. So what do these things look like again? So I've given you an idea of what the astrocytic tumor nuclei look like. So what does a diffuse astrocytoma look like, a WHO grade 2 tumor? So basically what we look for here is we look for normal neuropil in the background, and we think this neuropil is a little bit edematous and splayed apart. So you can pretty easily see axons individually traveling through this tissue. And what has caused this neuropil to become edematous and splayed apart? Well, there's a population, an abnormal population of astrocytic appearing nuclei here. They are hyperchromatic, they're dark, okay? And they're scattered somewhat willy-nilly through this tissue, all right? There's not, normal brain has an organization to it, right? There's going to be oligodendrocytes lined up along axons. There's going to be general, the white matter is coursing in a particular direction usually. But these cells are not really oriented in one particular direction. They're wandering about, and they look strange, okay? They look atypical, hyperchromatic, so forth. So this hypercellular brain tissue with abnormal neuropil and atypical astrocytes is indicative of a diffuse astrocytoma WHO grade 2. We don't see mitotic figures yet, so we won't call it grade 3. But if we start looking around and we start seeing more dense cellularity, and we start running into mitotic figures like this guy here, then we would call this an anaplastic astrocytoma. All right. GBMs, of course, have the characteristic pseudopalisading necrosis quite often, or at least a necrosis of some stripe, tumor necrosis. And in general, then they'll also show the thickened and reactive appearing vessels of vascular or endothelial proliferation. All right. So the general idea here behind what produces this lesion is that GBMs dump tumor necrosis factor into, or tissue factor, I should say. They dump tissue factor into the local vessels and cause thrombosis of the intratumoral vessels, and then that causes a necrosis of the surrounding tissue. And these tumor cells are mobile. Remember, they can infiltrate. So when they start sensing the local hypoxia, they flee from the area of necrosis and stack up on themselves and produce this pseudopalisading necrosis. And as they're fleeing, they produce VEGF, and that's what triggers the endothelial proliferation just beyond the area of necrosis. So oligos, again, you're seeing this, you're looking at normal neuropil in the background that is splayed apart somewhat, and you can more easily see the individual fibers within the neuropil. And then there's lots of extra cells added on top. That's the basic idea of of an infiltrating glioma, and these cells have rounded tumor nuclei and pericellular clearing. At higher grades, they have more cellularity and increased mitotic activity. Okay. So nowadays, we use molecular data to really help us classify infiltrating gliomas, and in adults, we look primarily for IDH mutations. So IDH wild-type tumors, our experience shows that IDH wild-type tumors in adults in general will behave in a fashion similar to a primary, quote-unquote, primary glioblastoma. So they'll present typically at a higher grade, and they, in general, quickly progress to become a GBM. If you detect an anaplastic astrocytoma, and that's what we call it histologically, but it's IDH wild type. We can't find an IDH mutation, and you're dealing with, say, a 60-year-old man, you would be pretty worried about that. That's going to actually behave much more like a GBM. Whereas if you're dealing with a 40-year-old man and you detect an anaplastic astrocytoma that has an IDH mutation in it, well, you're actually going to be a lot less worried in the short term because IDH mutant tumors progress more slowly. We have IDH mutant anaplastic astrocytomas that we talk about at Tumor Board in patients we made the diagnosis 10 plus years ago. So this really, the IDH mutation really makes a big difference in terms of whether you're expecting something to behave poorly or not. And then once you have an IDH mutation in a tumor, you divide them up based upon the presence or absence fundamentally of a whole arm 1p19q codeletion. So loss of 1p and loss of 19q, the whole arm. And if you have that, you call it an oligodendroglioma. And if you don't, you would call it an astrocytoma. And typically, IDH mutant astrocytomas will also show mutations in TP53 and ATRX. So this is just a pictorial version of the same thing I just talked about. So basically, the idea is you would have some progenitor cell, a progenitor glioma cell, and it acquires genetic lesions that take it in a particular area of gliomogenesis, all right? So if it were to become something akin to a primary adult GBM, it would show potentially EGFR amplification, P10 loss almost all the time, maybe a TP53 mutation, and almost always we would see some loss of CDKN2A, which is P16. You could also see if it becomes a pediatric type tumor, and I won't go into too much detail on this, but the primary genetic lesion in many pediatric infiltrating astrocytomas is a histone protein, H3F3A. So if you see that, you should think, pediatric infiltrating glioma. And then IDH mutations would drive gliomogenesis in a different direction, which would be primarily determined in terms of the diagnosis and the behavior by the presence or absence of a whole arm 1p19q codeletion. All right, so just a couple of years ago, we updated the WHO to reflect the impact of these findings on our diagnostic paradigm. So fundamentally now, you'll notice that in this characterization, there isn't a separate line of oligoastrocytoma. And since the 1p19q codeletion is basically an either or, it does or it doesn't finding, you basically we don't really think oligoastrocytoma exists in terms of as a molecular entity. So we eliminated that fundamentally from the diagnostic paradigm. And we classify these things as IDH mutant or IDH wild type and as 1p19q codeleted or not. So what does this mean for our new classification scheme? We still have a lot of the same terms. We use diffuse astrocytoma, and that would be plus or minus an IDH mutation, and that's in the diagnostic line. Same thing for anaplastic astrocytoma and glioblastoma. And then for oligodendroglioma, it by definition has to be IDH mutant. And so in order to diagnose an oligodendroglioma, you have to demonstrate an IDH mutation. And then you also have to demonstrate a 1p19q codeletion, all right? So you can do this by a number of different ways. Here at Emory, we do a cytogenomics microarray, basically look at the whole genome, and we can see, there's there's a whole arm of 1P and a whole arm of 19Q that's lost a copy. So oligoastrocytoma, the term still does exist in the WHO, and basically this means that, well, I think this looks histologically like what we used to call an oligoastrocytoma, but I have to call it NOS because I haven't done genetic testing, and most likely it actually falls into one of these two things. So sometimes tumors will come to us with a diagnosis of oligoastrocytoma from a location where they don't have access to some of the genetic testing that we do here. And then in that situation, we would be charged with trying to figure out, most likely, does it fall into one of these two categories? So poorly infiltrative gliomas. So these things go by a bunch of different terms. All right, you'll see a bunch of different names for these things in the literature. You'll see encapsulated glioma. You'll see low-grade neuroepithelial tumor. You'll see low-grade glioma. Fundamentally, it's a class of tumors that don't show as much of the single cell infiltration that we see with the traditional infiltrating gliomas, and they're typically, at least there's some potential for them to be surgically cured. Okay, you can cut them out, and they'll have some low risk of recurrence. Now, unfortunately, as you guys are familiar with, in many cases, these things may occur in a location where you can't cut the whole thing out, in which case we'll usually be radiating it and watching it over time. So these are glial neoplasms again, so they show S100 and GFAP and OLIG2 expression, and they're typically WHO grade 1 or grade 2 tumors. And the grading depends upon the histologic type and the evidence of proliferative activity within them. And they typically don't progress to higher grade. There are diagnostic categories that address that possibility, but they don't typically progress. And so MRI of these tumors usually shows an enhancing tumor. It's usually well circumscribed. It may have a cyst with a mural nodule. So the WHO classification for these things in general is, what falls into the category of poorly infiltrative glioma? Pilocytic astrocytoma would, pilomyxoid astrocytoma, which is grade 2, subependymal giant cell astrocytoma, which is a grade 1 tumor associated with tuberous sclerosis, pleomorphic xanthoastrocytoma. This basically looks a little bit like a pilocytic, but it looks big and weird, hence the term pleomorphic, and has some foamy cells, hence the term xantho. All right, there's a bunch of tumors in this general category. I won't go through all of them. But so let's look at some pictures of PAs. So this is pilocytic astrocytoma is the sort of flagship lesion of this general category. It's the most common one we would run into. And what do we see under the microscope? We see a biphasic proliferation of glial cells. And biphasic means it has two areas that look different. And so our two areas, number one is a very fibrillar area, and you see that to the right of the screen, and it includes a lot of pyloid tumor cells. So what does the term pyloid mean? It means hair-like, okay? So if you were to do a smear of these tumor cells, you would see this little elongated nucleus and two little glial processes coming off the two ends, little bipolar tumor processes that look very thin like hairs, okay? So you smear these guys out, looks like it has a bunch of hair in it, and you're like, oh, pyloid. But then the other thing that we see is these pink eosinophilic aggregates that are oftentimes deposited in the fibrillar area that are Rosenthal fibers, and we'll look at those at higher power here in just a second. And then the other area, the biphasic tumor here, is a myxoid area. And when you say myxoid in neuropathology or in pathology in general, you're meaning it looks kind of bluish, maybe a little bit loose, all right? And that generally refers to some type of ground substance deposition in that area. Ground substance looks bluish under the microscope on an H&E. But you'll see these more oligodendroglial looking cells in this area, very rounded tumor nuclei. And if you get a small sample of this, you can get tricked in thinking that it is actually an oligo. But close examination can usually help you out. So higher power on the fibrillar or the pyloid area. Here's an area with a ton of Rosenthal fibers in it, all these pink corkscrew-looking things. And then at even higher power, that's looks like kind of. I mean, the corkscrew is what's in the literature for this. I think this one looks a little bit more like a carrot, but your mileage may vary. And then the other thing that one would see in pilocytics and in other tumors in this general category a lot are eosinophilic granular bodies. All right, these are proteinaceous, rounded concretions, and they're usually seen in high density grouped together. They're pretty small. You'll see a bunch of them grouped together, and that'll draw your eye, but they're small. I mean, these are red blood cells over here, so that's 5 to 6 microns across, and they're looking pretty big in comparison to our EGBs. So pleomorphic xanthoastrocytoma, or PXA, WHO grade 2 by definition. And the tumor cells look a little bit bigger. They look a little bit more atypical than what we were seeing in that pilocytic astrocytoma. And so then they'll also have some foamy cytoplasm to them. That's the xantho portion of the name. But they'll also typically have a lot of EGBs. You see a lot of EGBs in pleomorphic xanthoastrocytomas, and they typically also show some perivascular inflammation. But in general, it's a solid, compact tumor proliferation that doesn't typically infiltrate a ton into the surrounding brain. So the genetics of a lot of the low-grade gliomas, the thing that we talk about primarily is BRAF. So supratentorial pilocytics and pleomorphic xanthoastrocytomas will show a BRAF V600E mutation quite commonly. And PAs in the posterior fossa and down in the spine typically have a fusion protein of BRAF KIAA1549, which produces either alteration produces constitutive BRAF activity, which is the likely driver for why these things become tumors. All right. So subependymal giant cell astrocytomas. This is another WHO grade 1 tumor. It shows this sweeping growth pattern, which is what's described. The tumor cells kind of run in groups, and they'll show a little perivascular orientation. Well, this is the first time we've run across this term in this lecture. So whenever you hear the term perivascular orientation, it basically means that the tumor cells are respecting the vessel. They're standing aside from vessels, and so you see that over here. This is a term that you'll usually hear used with ependymomas, but SEGAs will also show similar properties. And on higher power, a lot of the tumor cells look a little bit more like ganglion cells, i.e. they have rounded nuclei with a large central nucleolus and a fairly copious amount of cytoplasm. All right, so it's on ganglion cell-like tumor cells. But the main thing to remember is that subependymal giant cell astrocytomas are highly associated with tuberous sclerosis, and you'll see them along the sides of the ventricles. Looks like these little candle wax drippings along the sides of the ventricles. So you'll see a big sega and then kind of smaller little dots coming down from that look like like wax dripping off a candle. And those other smaller nodules are called subependymal nodules. Histologically, they look a whole lot like a sega. They're just small. You'll also see cortical tubers. Those also look a little bit like a sega. And then facial angiofibromas and cardiac rhabdomyomas. And remember, the genes involved are TSC1 and TSC2, which encode the proteins hamartin and tuberin. Ependymomas. All right, so we talked about perivascular orientation, which leads us to ependymoma. These are glial neoplasms that also tend not to infiltrate the surrounding brain, so they are also poorly infiltrative, but we think of them in a little bit of a different category than the poorly infiltrative gliomas I was speaking of earlier. They look and stain similar to ependymal cells, so they're GFAP positive, but they're also EMA positive. EMA is epithelial membrane antigen. This is as the name sort of alludes to, it's a protein typically seen expressed in epithelial cells, but ependymomas will also show EMA, and ependymal cells in general show EMA expression. So the behavioral and clinical outcome of an ependymoma depends primarily based upon how old's the patient and where is the tumor. Ependymomas that look exactly alike can have a very different clinical outcome based upon whether they are, say, in the fourth ventricle of a child, in which case the outcome is usually bad. If they're in the spine of an adult, and remember this is a tumor that looks exactly the same, the outcome is usually good. And nowadays we actually know that these things are molecularly different, as you would imagine. So something that looks histologically very similar can be molecularly quite different, and that explains some of the different behavior. Supratentorial ependymomas are a little bit more of a mixed bag in terms of their behavior. And then there's another category of subependymomas that are extremely good in behavior. These are usually seen in adults. And so these are usually enhancing, sharply demarcated periventricular masses. So our classification, again, subependymoma is grade 1, which this sort of alludes to its very low-grade behavior. And then myxopapillary ependymoma is a type of ependymoma that we run into down in the lumbar spine. And this is also WHO grade 1, but it does have a higher recurrence rate than the subependymoma does. Conventional ependymomas are WHO grade 2, and there's a bunch of different morphologic subtypes of ependymoma that don't have any clinical significance. They just look very interesting to us. Then if there's a lot of mitotic activity, we might call something an anaplastic ependymoma. But in general, the behavior of an ependymoma is more based upon the genetics or the associated clinical pathologic scenario. The grading doesn't make as big of a difference. So what does an ependymoma look like? So again, we see perivascular orientation of these pretty banal appearing tumor cells. So they're standing aside, they respect the vessel, and there's a lot of fibrillarity in between the tumor nuclei and the vessels, all right? So there'll be arrayed around the vessel here, and they'll group up a little bit as well. So they'll kind of make little groupings, and they'll step aside from the vessels. And so you'll see these perivascular pseudo-rosettes, which is what's basically produced by the perivascular orientation of the tumor cells. And the more mitotic figures you see, and the higher cellularity, the higher grade it'll get. But this is a grade 2 that we're looking at here. Grade 1, a subependymoma, looks a little bit like an ependymoma in that it has little groupings of tumor cells, and the tumor cells are sort of rounded, have banal nuclei, and there's a little bit of perivascular orientation. You can see these guys are kind of respecting this vessel, but the features are not as well shown as an ependymoma because you just don't have as many tumor cells. The main thing that strikes you about a subependymoma is that it looks super pink, all right, because it's got so many fibers in it versus the number of tumor cells. So oftentimes subependymomas will show like oceans of this pink material. I found an area with cellularity in it to take this picture. Then around it was a lot of pink fibrillarity. So a myxopapillary ependymoma, again, shows a similar perivascular orientation. So you see there's our tumor cells out here. Here's a vessel here in the middle, and they are standing well aside from it, okay? Myxopapillary ependymoma, it's a little bit of a misnomer. It's not really all that papillary. Papillary meaning like cauliflower looking or broccoli looking, okay? Myxopapillary ependymomas show a lot of myxoid deposition in the background, this bluish material again. And oftentimes you'll see this bluish material kind of in a band around vessels. And then you'll have these small banal tumor cells standing aside from the vessel. Remember, these are seen more in the sacral or lumbar spine. They do have some recurrence rate associated with them. So the genetics of ependymomas are, as I've mentioned, different in different age groups and different locations. And we could talk about this for a long time. It's very interesting to me, at least, but there's a number of different subtypes based upon more recent papers published on molecular profiling of these things using a bunch of different mechanisms. But for your tests, at this point, I don't think that a lot of those newer papers are going to make it onto a test yet. My hope would that they wouldn't be testing on you guys on that yet, because I think a lot of pathologists wouldn't know all that either. But in any event, there's the most common abnormality of an ependymoma would be on 22q, where NF2 is located. Oftentimes you'll see a 22q loss or loss of 22. Supratentorial subtypes of ependymoma are associated, many of them have a REL-A fusion, that's on chromosome 11, and then others will show abnormalities in YAP1. All right, so those are two subtypes of supratentorial ependymomas. All right, glioneuronal and neurocytic tumors. So what are these guys? So they have some glial differentiation, so they have some GFAP, S100, OLIG2 maybe, but then they'll also have tumor cells that express neuronal markers or markers along the lines of like synaptophysin, chromogranin, neurofilament, and nu-N being a mature neuronal marker. So again, these are tumors that are usually poorly infiltrative. They may be resectable. They're clinicopathologically somewhat similar to the poorly infiltrative gliomas. They're usually grade 1 or 2. And then by MRI, they're usually enhancing, often well-defined, and a ganglioglioma, for instance, may have a cyst with a mural nodule. Dysembryoplastic neuroepithelial tumor may be a wedge-shaped cortical mass associated in a patient with seizures. And then neurocytomas are typically peri or interventricular tumors. So the WHO classification of some of these would include ganglioglioma or gangliocytoma, that's WHO grade 1. And then if you have anaplastic transformation of one of those, it's a WHO grade 3, anaplastic ganglioglioma. Those are pretty rare. There's a subtype of these seen in kids, a desmoplastic infantile ganglioglioma. Those can be quite dramatic, be enormous tumors in a patient who really doesn't show all that much in the way of clinical symptomatology, and you take the thing out and the brain re-expands, and patients really never bothered by it beyond that. After that point, it's kind of an amazing thing if you get the whole thing out. So these are WHO grade 1 tumors as well. Dysembryoplastic neuroepithelial tumors, DNETs or DNTs, or WHO grade 1, and then neurocytomas are WHO grade 2. Usually these can be central or very rarely extraventricular. So what do these things look like under the microscope? A ganglioglioma is a grade 1 neoplasm that's mainly typified by abnormal ganglion cells. So you'll see lots and lots and lots of neurons scattered around, and they look ganglion cell-like. So that means that it has a rounded nucleus and a fair amount of plump cuboidal or rounded cytoplasm. Okay, most neurons, or you'll see a lot of neurons in the brain that'll have a pyramidal shape. These guys look more like a neuron that you would see in a ganglion. Okay, they're rounded. And then in the background, you have a hypercellular glial proliferation. So there's a ganglioglioma. So it's got the ganglion cell component and then a glial component in the background. A DIG. The main thing that strikes you about a DIG is that it has a desmoplastic response to it. So this is more of a fibrous response here, and that's typified by this area over here. Desmoplasia is a term that we use in pathology to reference a sort of reactive stromal response. We don't usually see desmoplasia in brain tumors, but in this one we do. But you'll see astrocytic cells and ganglion cells kind of scattered through it. But the desmoplasia is really what strikes you in a DIG. DNTs are also grade 1, okay? So these have very small pinpoint tumor nuclei. There's a whole lot of them. And they group up around axons and they group up around vessels. And they look, when they group up kind of alongside those axons or vessels, they look a little bit like what one would expect in a developing brain, where the cells are climbing up along radial glia to form the cortex. Okay, so these tumors were actually originally thought of as potentially being malformations because they had these what were called specific glioneuronal element, where you've got these little tumor cells lining up along the vessels or the axons. And so people thought, oh, it's a malformation. These things just like stopped in their development. And that explains why there's so many seizures associated with them, and we see them in younger people pretty commonly. Well, that all was great, but the thing is they do have characteristic mutations associated with them. And so there are genetic abnormalities that can help you define it. It's probably not a malformation, it's actually a tumor. So what we do see in these things, though, is these rounded tumor cells, these pinpoint tumor cells, will form little lacuna around neurons. And so the neuron will get this like myxoid deposition around it, this bluish material around it that will produce a pool that the neuron sits in. And it's a phenomenon called floating neurons. And there's a nice example of that here. There's your neuron, here's your pool, here's your little tumor cells sitting around at the edge of the pools wondering about what the neuron's up to. And the neuron is sitting there floating in the middle, okay? So central neurocytomas are WHO grade 2, and these are a proliferation of neurocytic tumor cells. And neurocytic cells look a whole lot like, honestly, they can look a lot like the cells of a pituitary adenoma. So you'll see this salt and pepper chromatin, all right? So what do I mean by salt and pepper? This is a great term used in a lot of pathology, but what does it really mean? It's basically like a mound of salt with some pepper sprinkled on top, okay? So the nice example of that would be right there. So the salt and pepper chromatin we use in pathology to think of as neurocytic or neuroendocrine cells. And so these will have a lot of synaptophysin in them, and they'll be nu-in positive as well. But they also make pseudorosettes. They respect vessels, and they produce pseudorosettes around fibrillary areas as well, like that. Okay? So let's see. What's my time looking like?
13 minutes.
Excellent. Okay. So embryonal neoplasms. So these are undifferentiated or poorly differentiated malignancies that we usually see in kids. They are basically, most of the tumors that we have been talking about up till this point, the tumor cells look like something that one would actually see in the body somewhere else. So you can look at glial cells and you would the cells of an infiltrating glioma, and you say, okay, those guys look kind of glial. They have a little, maybe a little pinkish cytoplasm, some spiculations coming out of them. It looks maybe fibrillar. An undifferentiated tumor cell just doesn't look like anything from the normal body. It may look like something that one would run into in a fetus, something that's developing. But these are just tightly packed nuclei that proliferate, all right? They may express a number of different types of antigens. They may show synaptophysin. They may show some GFAP. Rarely they would show markers that we associate with maturity, like nu-in. And then pineoblastomas and retinoblastomas, for instance, will show S antigen, which is a retinal protein. But in general, we think of these things maybe as having synaptophysin. Sometimes they don't really show much of anything in terms of protein expression that references a line of differentiation. Traditionally, we define these things by the combination of looking at the histology, and we look at where the tumor is, location of the tumor. But our molecular classification is becoming more and more important, as you would imagine. So the classification of these things, these are all WHO grade 4 tumors. One that we think of is ATRT, an atypical teratoid rhabdoid tumor, and that's defined by abnormalities in SMARCB1, which is on chromosome 22. And usually you'll see either a mutation or a deletion of SMARCB1 produces this wild-looking tumor. The teratoid in the name means that it can look a number of different ways and actually look like it's differentiating in multiple different directions. The rhabdoid part of the tumor name means that it has some rhabdoid tumor cells. It has a pink cytoplasm and eccentric nucleus. But in general, we think of these things having it's interesting from a genomic perspective. They may be relatively simple, other than the fact that they have some mutation in SMARCB1. Other CNS embryonal tumors. Formerly we talked about these as PNETs, and you'll still, of course, see these things referenced as PNETs, primitive neuroectodermal tumors. But now we've decided to change our minds and call them all embryonal tumors. Okay, that's part of what keeps pathologists employed. Is you got to change up all the classification schemes every now and again. So you got to stay ahead of the game, right? So in any event, so in the cerebellum. Embryonal tumors, we call them medulloblastomas, and there are a fair number of histologic subtypes of medulloblastoma. The one that has the particular importance for behavior is the large cell and anaplastic subtype of medulloblastoma. We'll show a picture of this in just a second. There's molecular subtypes of medullos as well. The four that we talk about primarily now, there's papers out there that divide these all sorts of different ways, but the four is what the consensus classification is right now, and that is the Wnt subtype, the sonic hedgehog subtype, the group 3 and group 4 subtypes. Group 3 oftentimes will show some abnormality in MYC, and group 4 is a little bit more of a mixed bag, sort of things that didn't fit into the other categories. In the pineal gland or the pineal region, if you see an embryonal tumor, we would call it a pineoblastoma. In the retina, retinoblastoma. And in the supratentorial brain elsewhere, we call these things CNS embryonal tumors. And there's actually been a lot of work done recently defining a bunch of different molecular subtypes of CNS embryonal tumors. And in fact, there's some of that work shows that some of these tumors really actually fit better into the category of glioblastomas, particularly in kids. So, atypical teratoid rhabdoid tumors. These are WHO grade 4 again. And what do I mean by this rhabdoid tumor cell? So we see these enlarged nuclei with extremely prominent nucleoli. The cells are staring back at us. And then they'll have these rounded eosinophilic concretions in the cytoplasm, which is what it gives it its rhabdoid name. And these concretions will indent and displace the nucleus. So the nucleus is kind of off to the side of the cell, and this big pink blob is in the middle of the tumor of the cell, and the nucleus has a big nucleolus staring back at you. In general, these are extremely aggressive and dire clinical situations. Classic medulloblastoma, and classic means classic histology, classic morphology. It could be a bunch of different molecular subtypes, but the histology we still call classic. And what is a classic medulloblastoma? It's basically a lot of primitive or undifferentiated tumor cells that pack closely together. The nuclei pack closely together. There's a little light fibrillarity in the background, and it produces pseudorosettes. So it'll make little spaces of fibrillarity with the tumor cells arrayed around the periphery. Okay. And then large cell or anaplastic medulloblastomas. These again are clinically dire, more aggressive tumors, these tumor nuclei are extremely enlarged, and they will pack together so tightly that they may wrap around one another. This cell-cell wrapping is a feature of a anaplastic medulloblastoma. So in general, embryonal tumors elsewhere will have a similar appearance, a primitive appearing nuclei, very dark, very hyperchromatic nuclei. Oftentimes will show some necrosis, this pink granular stuff with nuclear debris is necrosis. And then you'll see atypical mitotic figures. It'll be frankly malignant. So pituitary lesions, all right? The pituitary and the Sellar lesion, most tumors in this lesion, in this area, we are pituitary adenomas. This is something that we're very familiar with at this institution, and we do a fair amount of workup on our pituitary adenomas. So what is a pituitary adenoma? It's a neuroendocrine tumor of the anterior pituitary gland. All right, so neuroendocrine means it'll have salt and pepper chromatin. and it'll express synaptophysin and chromogranin, and then it'll also show some epithelial markers, keratins. And adenomas will also stain for one or more of the six pituitary hormones: FSH, LH, GH, ACTH, TSH, and prolactin. And then I left this in here this year because it may still be referenced. It's possible. There is a subtype of an adenoma called an atypical adenoma that expressed P53 and elevated MIB1, MIB1 being a proliferation marker. And we call these things atypical adenomas. The 2017 WHO has thrown that term out. It didn't make a whole lot of sense anyway. A lot of things show some P53 expression, and it was the atypical adenomas are only mildly more aggressive anyway. There's been a lot of struggle trying to figure out which adenomas are going to be more clinically aggressive, and we're still working on that. But in general, the main thing is that you would call something an adenoma if it recurs, but if it ever metastasizes, if it forms a lesion separately elsewhere in the CNS or outside, you would call it a pituitary carcinoma. Well, that's a pretty defeating scenario for a pathologist. I mean, our whole existence is predicated on being able to basically look at something and predict what it's going to do. Well, if your terminology is based upon what the thing has already done, you're not doing a whole lot. So, in any event, and if you have a metastasizing pituitary adenoma, you call it a pituitary carcinoma. Other lesions in this area may include those derived from the Rathke's cleft. You got a lot of things in the Sellar region, right? So you've got Rathke's cleft. So that could be endodermal cysts or craniopharyngiomas. Could arise from that. Meningiomas. You've got dural coverings over the sella. Posterior pituitary neoplasms, and then chordomas may arise from the clivus and appear as a Sellar region mass. Yes.
How often do you see those atypical adenomas?
In published series, they were 2 to 3%, and in our experience, really the key is how do you interpret your P53 immunostain, because and this was what caused that category to be so hazy to begin with. Because to me, if you say an astrocytoma has a TP53 mutation, if you do a P53 immunostain on that, you'll see a bunch of overexpression. So a lot of tumor cells will be positive. But for these adenomas, it wasn't actually associated necessarily with a TP53 mutation. It was mainly just looking at, well, there's a lot of these cells that may or may not have P53 expression, and there was no cutoff given. So it was just basically, it was an observation of elevated P53 expression. And so what you ended up with was different sites, different people would look at a P53 and reach a different conclusion. So what pituitary adenomas look like, you see lobules and sheets of banal neuroendocrine cells. So they have that, again, that salt and pepper chromatin, and a granular tumor cell cytoplasm. Endodermal cysts. These are basically look very similar in different areas of the brain. We define them based upon where they are. And so around the sella, we would call them a Rathke's cleft cyst. Or around the foramen Monroe, we call them a colloid cyst. But in generally, they all look the same. They've got a banal cuboidal lining that may have some mucin in it that sits on a fibrous cyst wall. All right. So there's your epithelial lining. There's some of the material in the middle of the cyst, and this is the fibrous wall. Craniopharyngiomas we would see in the sella or suprasellar. And these, the adamantinomatous subtype of craniopharyngioma is a squamous proliferation that produces this what's called wet keratin that produces these are called ghost cells, ghost keratinocytes. So it looks like it's a pink cell that has lost its nucleus, and you can just see where the ghost of the nucleus once was. But these will often have lots of calcification in them. But the ghost cells really help you make the diagnosis. Otherwise, you're looking for a prominent basal layer to the squamous epithelium, and then other areas that'll look more loose and more myxoid and look a little bit more like tooth-forming epithelium that's called stellate reticulum. Papillary craniopharyngiomas are another subtype of craniopharyngioma. These mainly are all squamous, but they don't keratinize, so there's no wet keratin. It's just piles and piles of squamous cells, and the term papillary comes from the fact that they do produce a papillary morphology, like a cauliflower broccoli, like I was saying. Okay. Then chordomas, these are eosinophilic to clear cells that arise, tumors that arise from the clivus, and they have a lot of myxoid background again, and they'll be chorded. There'll be chords and nests of these eosinophilic to clear cells, and the clear cells oftentimes will look a little bit bubbly in their cytoplasm, and the bubbly descriptor leads to a particular term for chordoma cells called phyzoliferous. Phyzoliferous being a Greek term for bubbly. All right. So phyzoliferous cells of a chordoma. All right. And I'm going to stop there. Thank you.
Thank you.